In the next 2 lessons, we will finish our lectures in cardiopulmonary diagnostics with important monitoring equipment, the indications and potential causes for inaccuracies for this monitoring equipment in both the acute and non-acute settings. This monitoring may be invasive or non-invasive and may be seen in patients with primary cardiovascular and pulmonary compromise, as well as in patients with multi-organ dysfunction. We will also discuss basic respiratory assessment as a very important diagnostic tool. Monitoring equipment contains the following components. 1. A device to detect the physiological event. 2. An amplifier to increase the magnitude of the signal from the sensor. And 3. A recorder or meter to display the signal. As discussed in previous lessons, the electrocardiogram monitors heart rate and rhythm and represents graphically the electrical activity of the heart. Heart rates above and below a preset value are set to trigger an alarm, and the cause must always be investigated. If no cause is found, then artifact may be due to faulty electrode placement, electrical interference, coughing, or movement. Therapists should be aware of the following indications on ECG for declining cardiac status. They include ST changes including elevation or depression, the onset or increase of PVCs, onset of ventricular tachycardia and fibrillation, progression of a heart block, particularly a third-degree heart block, and loss of pacer spikes. Pulse oximetry is an important tool for the respiratory therapist and provides a safe and instantaneous measurement of blood oxygenation. It works by measuring the differences in the visible and near-infrared absorbances of fully oxygenated and deoxygenated arterial blood. It is based on 2 physical principles. 1. The presence of a pulse signal generated by arterial blood, which is relatively independent of non-pulsed arterial, venous, and capillary blood and other tissues. And 2. The fact that oxyhemoglobin and reduced hemoglobin have different absorption spectrums. Inaccuracies to pulse oximetry readings may be caused by low perfusion states, such as low cardiac output or shock, vasoconstriction and hypothermia, anemia or abnormal hemoglobin, jaundice arrhythmias, including atrial fibrillation, intravascular dyes, such as methylene blue, that may be used to test the urinary tract for leaks and fistulas, and parathyroid studies, or may be administered to treat methemoglobin, dark nail polish, fluorescent light, motion artifact, and darker skin pigmentation. Blood pressure monitoring, although not usually performed by the respiratory therapist, also provides useful information. In the critical care unit, it is usually set up to assess pressures at a preset time interval. The systolic pressure reflects the compliance of the large arteries and the total peripheral resistance, and the diastolic pressure results from the runoff of blood from the proximal artery to the peripheral vessels and reflects the velocity of the runoff and the elasticity of the arterial system. Mean arterial pressure is also displayed and is expressed mathematically as MAP equals 2 times diastolic plus systolic divided by 3. It is not as accurate in non-invasive monitoring, especially in unstable patients with varying heart rates. It is an important indicator of hemodynamic tolerance and should be at least 60 millimeters of mercury. Normal MAP ranges from 70 to 110 millimeters of mercury. When listening to blood pressure sounds with a sphygmomanometer and stethoscope, the sounds, called Horotkov sounds, are as follows. 1. The first sound, or faint tapping sound with increasing intensity, indicates the systolic pressure where blood starts to flow through the compressed artery. 2. The start of a swishing sound due to the blood flowing through the changing compression on the artery. 3. Sounds increasing in intensity with a distinct tapping indicating blood flow is increasing as artery compression is decreasing. 4. Sounds become muffled, which may indicate diastolic pressure in children younger than 13 years old and in adults who are exercising, pregnant, or have hypothyroidism. And 5. The disappearance of sounds, which indicates diastolic pressure in adults and usually occurs 5 to 10 millimeters of mercury below phase 4 in normal adults. In states of increased rate of blood flow, usually secondary to medications, it may be greater than 10 millimeters of mercury below phase 4. In these cases, the phase 4 sound should be used as diastolic pressure in adults. As a respiratory therapist, we routinely use basic assessment tools to determine abnormalities and report findings. As such, they are an important diagnostic tool and should always be accurately performed and reported, as they may be the first signs of dysfunction requiring further testing. Respiratory rate is one of these tools. For adults, normal rates are between 12 to 18 breaths per minute. And when the patient is tachypnic, it may indicate a variety of conditions including fever, atelectasis, hypoxemia, anxiety, and pain. Bradypnea may be found in head injuries, drug overdoses, or in sedation. Other indications of respiratory distress in addition to increased respiratory rate are nasal flaring, most commonly seen in children and infants, intercostal and sternal retractions, visible expression of distress, increased use of accessory muscles, and paradoxical breathing. Level of consciousness, or LOC, is also of critical importance when assessing patients. As therapists, we often note whether the patient is awake, alert, and aware, and responsive to stimuli or not. Any altered levels of consciousness are described as either decreased cognitive function or inability to be easily aroused, and any changes in LOC requires further assessment and diagnostic tools. Patients may be described as one of the following. 1. Confused, which describes disorientation that makes it difficult to reason, provide medical history, or to participate in a medical examination, and may be due to sleep deprivation, fever, medications, drug or alcohol intoxication, and post-seizure. 2. Delirious, which is used to describe an acute confusional state with impaired cognition, attention or alteration of the sleep-wake cycle, hyperactivity or agitation or hypoactivity, or perceptual disturbances such as hallucinations or delusions. The causes of this state may be alcohol withdrawal, severe infections, organ failure, medications, or recreational drugs. 3. Lethargic, which describes severe drowsiness, listlessness, and apathy accompanied by reduced alertness and again may be due to the causes previously listed. 4. Obtunded, which is a reduction in alertness with slow responses to stimuli requiring repeated stimulation to maintain attention, as well as prolonged periods of sleep and drowsiness between these periods. Causes include poisoning, stroke, brain injuries, sepsis, and advanced organ failure. And lastly, 5, the unconscious patient, who does not respond to stimuli due to cardiac arrest, stroke, or other serious diseases and conditions. In the ICU, a bispectral index monitor, or BIS, may be used to determine level of sedation. It is a small, flexible sensor that is applied to the forehead and temporal region and measures muscular and cortical activity. It is recorded every 15 seconds, and the value ranges from 0, meaning no cortical activity and full suppression, to 100, meaning the patient is awake and there is no suppression. This can help titrate sedatives, with 60 to 70 being the targeted range to provide light to moderate sedation. It is also useful for the therapist when assessing the patient for weaning from the ventilator, as heavy sedation needs to be removed prior to weaning trials.